Welcome everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniMeterHealth.com, which is dedicated to teaching you about the human heart and its illnesses across the globe through our social media channels. I thank you for your enthusiastic interest in watching, learning, and sharing with your loved ones, with your colleagues, with your residents, fellows, and medical students alike, and showing the interest to really support my cause in educating the human heart and its illnesses freely to all. Once again, thank you for bringing about the human wellness and the health and the health to all. Without any further ado, I'd like to delve into the subject matter. Today, I'd like to introduce you the subject of Marfan Syndrome. This is an autosomal disorder, and it's heritable, obviously, and it has a gene which is responsible for its manifestation. That gene has undergone a mutant change, and it's responsible for a protein called the fibrillin 1, which is present within the connective tissue. And as a result, the structure or the texture of the connective tissue, if you will change. And therefore, the manifestations phenotypically, which we'll just follow and tell you exactly that happens. This gene is mutant, and therefore it is also responsible for a TGF protein signaling, if you will, and it's called, it's not TGIF, so it's not even Friday yet. So transformation growth factor beta signaling, if you will. And so one of the things that you'll remember is the TGF beta signaling and the fibrillin 1, which is protein responsible for the structure of the connective tissue, if you will. So basically, these are your genetic abnormalities, and as I said, it's an autosomal dominant. So just remember that it's obviously heritable. So one runs into the family. It's not X-linked. It's not, it could be present in men and women both. Having said that, now what are the phenotypic features? Well, the phenotypic features, obviously, one has to really see clinically. And so the first important thing that occurs when you start examining, there is a subluxation of the lens in the eye. So it's called ectopic lentis. That's very, very specific. And it's a very simple test. Obviously, you're just examining the eye and you see this. When you come to the oral cavity, there's a higher palate, or the higher and more crowding of the dentition, if you will. So higher palate, and of course there might be mandibular occlusions that can occur, but higher palate is quite prevalent, but it's not specific. Ectopic lentis is very, very specific. Then we come to the musculoskeletal, if you will, and the musculoskeletal will define a very tall individual with a tall stature, has long digits, and if you look at the arm span is actually longer than the height, and the ratio could be more than 1.05, if you will. And there might be scoliosis or other abnormalities of the spine, and then people also start to see other features like sternal carinatum or sternal abnormalities. And then, of course, there's a wrist sign where the thumb is overlapping the little finger, if you were to wrap it around the wrist, and all the thumb sign, if you will. And the thumb sign is where the distal phalanx actually protrudes when the fist is made. So thumb sign and wrist sign could be, but they're not specific though. Having defined the phenotypic features, let's move on to other features which are very important, obviously, and these are cardiac features, because that's what we are here to discuss through this. So aortic dilatation, where the root is dilated, and then as a result, the person develops aortic regurgitation, and as a result, there's further complications or progression of the dilatation that leads to a dissection. So remember, aortic dilatation, aortic regurgitation, aortic dissection. These are very, very specific signs based on an echo finding. So remember, you do an echo, you will decide whether these are very specific, and you can clinch the diagnosis of Marfan syndrome rather easily. And then if you were to do an MRI or a CAT scan of the head, one can see a dural ectasia. So a dural ectasia is quite prevalent in these patients, and this is again a very, very specific sign. So I'm just marking these asterisks here. So what are the three signs which are very specific? One is ectopia lentis, subluxation of the lens, dural ectasia, which is present and diagnosed based on an MRI of the head, and then of course based on an echo one can diagnose aortic dilatation and aortic dissection or aortic regurgitation. So having defined that, let's understand what's going on in the heart. Now, this is the aortic root. The angle of the aortic root versus the sinuses of Valsalva within the aortic aortic root here itself, that is changed. So in other words, the ascending aorta and the angles here are changed. As a result, now let's draw this in a magnified way here in this fashion. So you're looking at, this is what the aortic root looks like, and then these are your valves, obviously. So when the valves are present, one sees that the aortic root tends to dilate more and more, and as a result, more aortic regurgitation will develop, and obviously that will lead to increased further dilatation. So aortic regurgitation I'm showing here in this fashion. So the aorta tends to dilate even further and further. Now there are certain criteria. So aortic dilatation, if it is present more than 45 millimeters, remember, you should be able to recommend surgery or repair. Now this is based on European Society of Cardiology criteria. But if you were to look at the American Heart Association or the ACC, American College of Cardiology criteria, they define that more than 50 millimeters or equal to 50 millimeters should recommend a repair. So there's a slight difference between European criteria and the American criteria for recommending surgery or repair, and 45 millimeters for aortic dilatation according to the European recommendation, and to the American recommendation it's 50 or more. So the criteria by dilatation is slightly liberal in the American guidelines, but just so that you know. However, there's only one exception to this, and that is pregnancy. Remember, pregnancy is a risk factor in Marfan's. It's a high risk factor, and therefore their recommendation that even at 45 millimeters, one should operate, because you want to wait for the complication to occur. You want to get there before the problems arise. So if somebody's pregnant, you want to make sure that this person gets operated, or even if the pregnancy is planned and somebody has 45 millimeters, the lady has 45 millimeters of dilatation already existing, you should operate this person before the pregnancy is planned. Okay, having defined those criteria, and there are a couple of other criteria which one comes across, and that is like rate of change. If there is a rate of change, for instance, I'll call it rate of change of the aortic root dimension. If it is more than 5 millimeters per year, now this is by the ESC criteria, European, but rate of change of more than 10 millimeters, again we are in American guidelines we are more liberal. So by the ACC criteria, it's more than 10 millimeters and more than 5 millimeters with the European criteria per year, based on what the baseline aortic root dimensions are. So say, for example, somebody begins with a 39 millimeters dilatation today, and a year later you were to look at and it's gone to say 44. Now that's a difference of 5 millimeters. So European criteria has been met, and you could repair. You could conceivably repair. You don't want to wait beyond 12 months and repeat another echo. However, one caveat I'll suggest is that you're better off doing an echo between 6 to 12 months in these individuals to follow their aortic root progression. Don't wait for 12 months. Why wait for 12 months when you're starting, say, at 42 millimeters already, and next thing is you'll have a 10 millimeter dilatation and then you want to operate? You do not wait for the criteria to be met. Sometimes you want to do a non-invasive study. It's a very simple study. It takes only about 10-15 minutes to really complete a quick echo, especially if you're looking only for the aortic root progression in a follow-up echo. So you're looking at, plus the aortic regurgitation that you'll obviously look at as well. So the whole point is that you might want to repeat an echo between 6 to 12 months, and most clinical centers, they're doing that. We define the clinical features, we define the actual pathology, the genetic morphology, and then, of course, what the aortic recommendations are for repair. Let's quickly look at what aortic regurgitation can look like within the scope of this video, because it has been dealt with somewhere else, I believe. I think so. And I'm defining the echo here in my apical window, if you will, on the echo. And if you were to look at, obviously, this is the right side. These are your tricuspid valves. Here is your mitral valve. And along comes the aortic valve right here. And this is your aortic root. So this being the RV and LV for those who are interested in knowing where things are now in terms of our, because remember on that echo, the heart is inversely represented. So the ventricles are on the top, just for the sake of the medical students. I know the cardiology fellows and the residents know it. And this is your RA and this is your LA, left atrium. Okay, so the heart is inversely represented on a 2D echo. It's the apical view, 4-chamber apical view. Okay, so now the aortic regurgitation obviously occurs in diastole, so you will see the aortic regurgitation occurring right here. And as it goes and progresses, it becomes more and more severe. So we can show it by mosaic colors if you like, and make it a little more what it looks like actually on an echo. And this is how the presentation would be. So a lot of it would be very, very mosaic pattern. And these mosaic patterns will define more so of the echo, if you will, in terms of the aortic. So this aortic regurgitation is measured by 3 parameters. Remember that. One is how far does it travel within the LV cavity. So how far? If it is traveling 1/3, if it's traveling 2/3, or if it's traveling here. So you can define mild, moderate, and then severe variety, depending upon how far does the aortic regurgitation travels. The second thing that you can do is do a pressure half-time study. And if you were to do the pressure half-time study, it'll appear the following way. I'll just draw it here for you for the sake of it. So if you were to do this, one sees that the pressure half-time could change the following way. If the acuteness of the drop of the end diastolic pressure during the time when the aortic regurgitation is occurring, that defines the severity of the AR. The longer the pressure half-time takes to drop to half the pressure from where it began, the longer it takes, the lesser is the aortic regurgitation. So the definition is pressure half-time less than 250 milliseconds. That means more acute. Obviously, therefore it is quick. So this is severe. And greater it takes beyond than 500 milliseconds. Remember, these are milliseconds. The milder it is. So one can look at the pressure half-time. The third way to look at what you call the severity of the aortic regurgitation is looking at the VC, which is the vena contracta, the width of the measurement that's done. So that's called the vena contracta of the AR. And again, here there are criteria. If it is less than 0.3 millimeters, it is mild, obviously, because it's so thin. But if it is more than 0.5 millimeters, it is considered as severe. So 5 to 7 obviously is very severe in certain criteria. So 0.3 or less is mild. So having defined the aortic regurgitation quickly in the setting of Marfan's, I think we have completed our discussion in this video vignette where we talked about when to recommend for surgery based on ESC criteria and the ACC criteria, 45 millimeters by ESC and 50 and above for ACC criteria, except pregnancy where you can operate even at 45. Just remember that. The 3 specific signs of Marfan's, do not forget ectopic lentis, aortic dilatation by an echo, and of course dural ectasia by the CNS test, which could be a CT or an MRI, preferably an MRI of the brain. So thank you again for watching Marfan Syndrome. I hope you have learned And please do spread this knowledge to your friends. Have more people associated with us, because primarily we are offering this knowledge freely to all across the globe. And I thank you again for your enthusiastic interest. If you like this presentation, do not forget to press the like button, because that's one way we can get a feedback from you guys that you're watching it, one, and two, you're liking it. And do comment and do suggest and ask questions, because I'll freely again interact with you and be able to at least understand what you desire to learn, and if there is any suggested subjects or topics that you'd like me to discuss, I'll happily do so if they have not been covered yet. Thank you again for watching MuniMeterHealth.com, your favorite website. Once again, Dr. Jaitly, and thank you again.